Uh, Today we'll be discussing on one case of one patient. He's a 42-year-old male patient from Katpadi, came with complaints of 2 weeks history of breathlessness and 1 day history of high-grade fever with chills and reduced urine output for 1 day. So for the history, he was apparently well until 2 weeks back. He started having complaints of breathlessness in serious onset, gradually progressive, started as NOHA grade 1. And by the time he came to us, he was already in grade 4, and he also had complaints of orthopnea and 1 day history of high grade fever with chills, with reduction in the urine output, and 1 day history of vomiting also. Non-bilious, non-blood stain vomiters, excessive fatigability also. Otherwise, there was no pertinent negative. He didn't have any complaints of abdominal pain or loose stools, no cough, there was no altered sensorium or headache, no giddiness, no palpitations or chest pain. For the past history, before he came to us, he was admitted in GH in GVMH, and for which he underwent debridement. He had a Fournier's gangrene. He was admitted with that for 1 month. So 35, he got admitted. I mean, he underwent the debridement over there, and he got admitted. He got discharged on 6th of July. So June 30th, he underwent the debridement. July 6th, he got discharged. After that, he came to us on July 20th. So that's almost like 2 weeks after he got discharged, he came to us. And he's also known case of type 2 diabetes on OADs only. So similar history was there. So he had a history of Fournier's gangrene 2 years back also, for which he was debrided in a private hospital. So when he came to us on examination, his vitals, he was tachypneic, tachycardic. Also, he was requiring positive pressure ventilation for his desaturation to maintain 100%. And he also was hypertensing. He required a single vasopressor to maintain his BP. He was also using his axillary muscles of respiration, but there was no palatal sinus clubbing. There was no nodes palpated. There was no JVP elevation. There was no pedal edema also. Systemic examination, CVS S1 S2 was normal. Respiratory system was normal, and per abdomen was soft and non-tender. CNS, he did not have any cross-focal neurological deficits. So for the local examination, because he had a recent debridement, he had a scrotal wound over 15 by 12 centimeters of the left hemiscrotum extending into the right side. So there was a Fournier's gangrene with a mild mucopurulent discharge being noted in the ED. But when he came to the ward, he had only, he was admitted in the ICU because he was hypertensing. He had only serious discharge at that time. So summary, he's a middle-aged gentleman who was a known diabetic. Has come with complaints of fever, decreased urine output, and worsening breathlessness. In the background, he had a Fournier's gangrene, for which he underwent a debridement like 2 weeks back before he came to us. So for the differentials, here it's a clear-cut septic case. So he has come in septic shock to us with the multi-organ dysfunction, probable ARDS with the renal dysfunction. The only differentials we can think of is for the etiological source. So one is he had a Fournier's gangrene, which was apparently there, which was obviously there. And first thing we'll think of is the Fournier's gangrene, which might have got infected, and he would have presented with the ARDS to, with the septic shock to us. Second thing, he had a recent hospitalization. He would have picked up a hospital-acquired UTI or a catheter-associated UTI or a hospital-acquired pneumonia or a abscess or a prostatic acid, which would have seeded from the Fournier's gangrene. So these were our differentials when he first came to us. So basic evaluation from the ED, apart from the procal, he had a neutrophilic leukocytosis. He had a very bad acute kidney injury here with a intrinsic renal injury he had. Actually, he had a CKD also, which was not diagnosed. The baseline grade was 3. So he had an AKI on a CKD. Apart from that, he had a very severe acidosis with a bicarb of only 6.5 with the lactates of 4.4. The shock was not due to the cardiogenic shock. ECG was normal, and there were 2 sets of cardiac enzymes were also normal. So for the diagnosis as of now, what we have is, so chest X-ray did not show any patch. So when the urine protein was sent, it showed some pyuria also. Blood and urine cultures were taken and sent. Ultrasound abdomen showed a bulky right kidney. So probable pyelonephritis was thought of. And so at this time, if at all he had a pyelonephritis because of the Fournier's gangrene or because of the Fournier's gangrene is infected, that is causing a septic shock. So what will be the organism we can expect to isolate from the blood or the urine? It will be, so if it is from the Fournier's gangrene, it should be either an MSSA or an MRSA or an E. coli, Proteus, Klebsiella, Pseudomonas. These should have been the organism if the source is the Fournier's gangrene. So this is what we had in his blood and urine culture. He had grown Burkholderia caenocepaceae. So this is actually, we'll talk about this bug. So the final diagnosis we had was a septic shock with a multi-organ dysfunction, secondary to a Burkholderia caenocepaceae bacteremia. Probable secondary to a UTI or a Fournier's gangrene is what we thought when the patient came with a septic shock and diabetes mellitus. So what is this organism? So Burkholderia cepaceae is again an NF-GNB like Pseudomalley. Pseudomalley we all know about Burkholderia pseudomalley. This is also an NF-GNB. There are more than 20 species of Burkholderia cepaceae complex. So why specific importance to this Cenocepaceae is this usually Burkholderia cepaceae, where do we see is usually when patient comes have cystic fibrosis or come with lung diseases, when patients have chronic granulomatous diseases, when we see the Burkholderia cepaceae commonly. This Burkholderia Cenocepaceae has a higher rate of mortality among all the Cepaceae complex. It has a higher rate of mortality. It has a 5-fold higher rate of mortality, and it causes severe bacteremia also. When we look at the literature, so basically, this Cenocepaceae complex, why is it very virulent? It has an efflux pump mechanism, and it has a production of beta lactamase also. That is why it forms many resistance. And apart from that, it is found to be grown in many disinfectants and antiseptics also. So very rarely it causes severe bacteremia. And so some patients, like when looking at the literature, when some patients are affected with the Cenocepaceae infection, many patients had a prior surgical history. And this Burkholderia Cenocepaceae, the most important thing is it grows on anything literally inside a hospital. So these were the case reports which are taken from hospital. These are the so whenever a hospital is being like many patients are admitted with a Cenocepaceae infection, like in the hospital when they develop a Cenocepaceae bloodstream infection, they start looking for the hospital acquired source. So even when we had many Acinetobacter baumannii infection in our ICU, we were looking for sources inside our ICU. Like every second patient on the second day of intubation itself was getting ACV infection. Likewise, all these hospitals, whenever there's an outbreak of a Cenocepaceae infection, when they tried to find out the source, everything was either from the things which they were using for all the patients, like a Ringer lactate solution, which was used to flush the IV set for all the patients, or even in the vials of antiemetic drugs, this has grown. And alcohol skin antiseptic, but this was from contaminated water, which was used to dilute the skin antiseptic, and the salbutamol nebs, which was being commonly used for all the children in the hospital. One more thing is in this outbreak, if you see in this hospital, it has been it has grown in the amikacin vials. In the antibiotic vials, it has grown. One case report where in the lubricating gel of the ultrasound probe which we use, from the lubricating gel, this was isolated. When many patients were undergoing ultrasound, when who grew a bloodstream infection of Burkholderia Cenocepaceae, they found that this lubricating gel has been isolating this organism. So duration and treatment for the Cenocepaceae organism is usually based on a clinical response only. Most of these organisms which have been isolated, they have been treated by ceftazidime or meropenem or cotrimoxazole. So duration is based on clinical response. There is no hard shot cutoff rule like how we have for melioidosis. There is no particular duration of therapy like this many months, this many days of intensive phase and this many days of continuation phase. It's based on clinical response. Most of these bloodstream infections which was treated previously, they received 2 weeks of IV antibiotics of ceftazidime. With this, the patient had proper clearance and they were discharged. But there was one case report which where the lady required 6 weeks of IV antibiotics also. So our patient, so he was treated with ceftazidime. He was also sensitive for, susceptible for ceftazidime or ceftazidime trimoxazole also. We treated, like after the clearance was achieved, we treated him with 2 weeks of IV ceftazidime. So what we think is like he also underwent many ultrasound scans and he underwent a urinary, catheterization also, and he underwent a surgery also. So probably from that hospital, he might have acquired this like previously before getting, because he grew Burkholderia from Cenocepaceae from day one when he came here. So day one blood culture, he grew it, and so the prior thing was only in the hospital stay was only 2 weeks before this hospitalization. So he could have acquired it from any of the things which has been used in the hospital. So basically, it's an iatrogenic. And the second thing, that hospital could be brewing like it can be like many other patients also could have been affected with this. So he was treated with ceftazidime and discharged, and he is doing well now. His creat at the time of discharge was also reduced. His creat was 5. He was doing well. His afebrile at the time of discharge.
So what do you think is the source of infection here?
We are not clearly sure, sir, because he has undergone multiple screenings also for the sepsis. So the thing is, when you isolate an organism, so do not always think about the source of the organism. Like Cenocepaceae infection, it's not usually doesn't form usually.
I get it all, but does he have any long line, anything?
He had a catheter, sir.
I understand. Urinary catheter, but I'm asking about
long lines.
Long lines, anything?
No, sir.
in the previous hospital. I understand it's one of the nosocomial infections, very common nosocomial, as you said well. And it's clearly maybe sometimes it be respiratory infections of in a chronic lung infection patients. Other than that, as you said, it's an outbreak settings. I think even in CMC, we have done a outdated institution, our pediatrics, it's already published. It's there in for pediatric outbreak is also there. It's from the gel of the ultrasonogram things also isolated. But the one-off case, no, this if it's an outbreak, I don't know about the previous hospital unless you inquire about it. It's a part of a outbreak situation or else it's isolated case. Let's assume it's an isolated case. What do you think would be the source of infection most likely in
Probably,
him?
probably the IV lines or the he has been undergoing a surgery also. So anything from the surgical side.
Yes, as you said, this a found here is very rare. I understand wound infections can be secondary or like it's a hospital, no? So it can be just you can isolate from the wound, but doesn't mean that it would be the primary coming from skin infections. It's unusual for that. So Fournier's gangrene, as you said, is predominantly either gram positives to be go with polymicrobial things, rather definitely not from cynosephagia, not coming from the skin. Other things I don't know whether the jelly what they use for catheterization or the catheter also because urine also isolating, but still it's all speculation only because, but definitely he has a bacteremia that we can't ignore. And as you said, this syndosephagia, unlike Burkholderia, need not to go by long. You don't require maintenance therapy at all. It's just based on syndromes. If it's a bacteremia, whatever you treat for a bacteremia, that is would be the duration. And if it's most likely other source would be your lung. So it would depending on is whether it's a hospital acquired VAP or bacteremia, line related bacteremias usually would be the common. So you can stick to 10 to 14 days depending on the underlying syndrome.
Sure.
Present.